All right, we're going to talk next about nicotine. Of course, nicotine is the primary psychoactive drug in cigarettes, chewing tobacco, cigars. It's also sometimes used as a drug of abuse or as a study aid with nicotine patches and nicotine gum. So we'll talk pretty good length about nicotine. Keep in mind the following things: the most preventable deaths, the cigarette smoking, is the number one preventable cause of death in the world. Worldwide, there are hundreds of thousands of people who die every year from lung cancer, coronary heart disease, chronic pulmonary obstruction, stroke, other cancers, secondhand smoke. While we have been making great strides in reducing cigarette use in the United States, we have reached the point at which we've kind of plateaued, and it's about 15 to 20% of adults, much more males than females, smoke, and we now think we're at the point where we are what we call hardened smokers, and of course, people who start smoking are replacing those who stop. It's one of the three most widely used psychoactive drugs. It's the most preventable cause of death, disease, and premature death. Its current use fell from around 50% in 1965 to around 25% in 1998, and we're holding right around the 20% mark, which is still 1 in 5 adults. Average starting age for people is declining. 9 out of 10 are addicted by age 21 for those who do start using cigarettes. To give you a little history, no society that has ever adopted tobacco use has ever given it up. It's pretty potent. This is the only drug of abuse that is native to the Americas, in particular North America. The word tobacco actually comes from a two-pronged tube used by natives of Central America that used to be made to make snuff. It was used from Paraguay to Quebec. Widely speculated that tobacco has been cultivated in the Americas since 6000 BC, so long history. And it was given to Columbus when he landed at San Salvador in October of 1492. So long history of using tobacco. It was really introduced by Jean Nicot, who first sent tobacco seeds from Portugal to Paris in the 16th century and actively promoted its medicinal use. Ironically, he claimed that lung ailments could be cured by tobacco. Of course, they could be cured by killing you. Within a decade of Nicot's seeds' arrival in France, the plant had made its way to England, and quickly thereafter to Virginia and other New World locations. Nicotine was first isolated in 1828, and its molecular formula was established in 1843. In 1903, nicotine was first successfully synthesized by these folks. So, relatively long history of the use of tobacco. Nicotine itself was isolated and synthesized in the 20th century, which is, of course, the point at which tobacco companies were able to add nicotine into tobacco. And now, of course, we have higher nicotine-producing tobacco plants versus relatively lower nicotine-producing tobacco plants, etc. Now, to give you an idea about the pharmacokinetics, in 1828, nicotine was separated out from tobacco. It's one of about 4,000 compounds released by burning of tobacco. It's a colorless, volatile liquid alkaloid. It's not well absorbed from the digestive tract. Most chewing tobacco and snuff is actually transdermally absorbed or submucosally absorbed. A number of children will poison themselves each year from eating tobacco, but that, we think, is from exposure to pesticides that are in tobacco. The amount actually delivered depends on how a cigarette is smoked. So the amount of nicotine delivered to a person is highly individual. And this is a really important point I want to emphasize. When a person smokes a cigarette, they can precisely regulate the amount of nicotine they get by inhaling at a certain rate to a certain depth, holding the smoke in for a certain amount of time. It is a highly precisely regulated amount of nicotine, and that's very hard to mimic, and that's one of the things we're going to get into when we start talking about treating nicotine addiction here in a bit. is it's difficult to match that. Smokers are very good at regulating the amount of nicotine. That's important because it has a very low tolerance range. They have to get to the point where they're no longer in withdrawal, but not to the point that they're dizzy and nauseous. High levels of nicotine are highly difficult to tolerate. People get nauseous, they throw up, they get very dizzy. It's very, very problematic. Nicotine is metabolized, again, by the hepatic enzyme cytochrome P2A6, which may be inhibited by SSRI antidepressants again. Something to keep in mind. In terms of the nicotine yield per cigarette, they have steadily increased, as you can see from this table, whether through different tobacco growing methods or by being added to cigarettes is hard to say. Menthol cigarettes have higher nicotine, and in fact there is something about menthol that increases the yield of nicotine. I can't remember what the whole chemistry there is, but menthol cigarettes have a very different addictive property than do other cigarettes. It's absorbed from every site on or in the body, so it is absorbed by the skin, by the lungs, by the nasal passages, gums, teeth, everything. It's absorbed everywhere. So when you go out to a smoky bar, you're absorbing nicotine everywhere. It's the reason why you stink so bad when you get home, because you've absorbed so much of that. So that's something to keep in mind. In terms of cigarettes, cigarettes are comprised of flue-cured tobacco, which makes an acidic smoke that reduces absorption from the mouth. So nicotine there is usually inhaled from the lungs, where pH has no effect on absorption. Nicotine is suspended in cigarette smoke in the form of minute particles, i.e. tars, which is quickly absorbed into the bloodstream from the lungs. And again, this is whether you're smoking it yourself or experiencing secondhand smoke. Pipe and cigar tobacco are air-cured, which makes alkaline smoke. So the nicotine there is absorbed to the mouth and doesn't have to be inhaled. So people who smoke cigars or pipes don't actually inhale. There is some question about doing what's called harm reduction in the tobacco literature, which is trying to get people to use a different kind of tobacco to get their nicotine to reduce the risk of lung cancer. Of course, it just shifts the risk somewhere else. Nicotine is quickly and thoroughly distributed in the body to brain, placenta, and all bodily fluids, including breast milk. The liver metabolizes 80 to 90% before excretion by the kidneys. Elimination half-life of nicotine is relatively fast, around 2 hours. The major metabolite of nicotine, which is cotinine, which is the basis for testing for tobacco use. You can actually detect the presence of cotinine in the urine of smokers. With an elimination half-life of 2 hours, means cigarette smokers usually need another cigarette every few hours. Probably have noticed that amongst your friends that smoke. And of course, there are certain things that can affect nicotine metabolism and its effects, including alcohol. For smokers, carbon monoxide is actually detectable in their breath for hours after a cigarette. I think it's 12 hours. In my lab, we test for whether or not someone's been smoking with a carbon monoxide breathalyzer. We're going to talk here in a bit about some of my research regarding the cognitive effects of nicotine abstinence or nicotine withdrawal. But carbon monoxide is something that you can detect still in the breath of somebody who hasn't had a cigarette in 10 hours. So that's how much carbon monoxide is in their lungs and in their blood, and that's obviously a problem. Something else to keep in mind about smoking, it's not just the nicotine that folks are smoking, but carbon monoxide, methanol, arsenic, methane, acetic acid, butane, cadmium, stearic acid, hexamine, toluene, ammonia, paint, all of these things that are being absorbed through that smoke. So it's the reason why it's so bad for you. So let's talk then about the mechanism of action of nicotine. Nicotine has a lot of effects in the brain. The NMD receptors, in fact, the nicotinamide methyl deaspartate, the NMD aspartate receptor. The nicotine affects similar receptors to that. In fact, it's involved in GABA. Nicotine is a GABA antagonist. So it occupies and activates what are called nicotinic cholinergic sites. At low doses, it stimulates those receptors. At high doses, it will actually block the receptors. Very dose dependent. It does cause the release of dopamine, which may be responsible for some of the reinforcing properties. It has effects on acetylcholine and glutamate. And we know that nicotine has some effects on memory. In fact, there was some thought that nicotine might be a treatment for dementia in older adults. The problem is you can't give them high enough doses to get an effect without making them very nauseous. So there's some question about whether or not nicotine-derived drugs might help treat dementia, stave off Alzheimer's disease, and so far there hasn't been much evidence of that. There is evidence that providing nicotine to healthy younger adults does have effects on memory, and we're going to talk about how withdrawal from nicotine does have a significant effect on memory. So to have an idea about these nicotinic acetylcholine receptors, these are related to GABA receptors. Related to GABA. In fact, one of the things that happens is neurons start to develop this ability to respond to nicotine. And when you take away the nicotine, the GABA levels are so high without the nicotine because they've been balancing out. The nicotine's not there to balance them out. And that's one of the reasons why there's a significant effect on memory. There are a variety of pharmacological effects of nicotine. Initially, it causes nausea and vomiting by stimulating the vomiting center in the brainstem and sensory endings in the stomach. This becomes tolerant after a while. One of the smartest things you can do if you catch someone smoking a cigarette for the first time is make them smoke the whole thing at once. After throwing up profusely, they won't probably do that again. It does stimulate the hypothalamus to produce antidiuretic hormone, causing fluid retention. Reduces activity incoming from muscles, producing relaxation, which is one of the reasons it might be perceived as anxiolytic. Does increase heart rate, blood pressure, and contractility, but carbon monoxide in the smoke combines with oxygen better than hemoglobin, so it decreases oxygen carrying capacity. That is, it suffocates the cells. This is one of the reasons why long-term it's bad for cognition and brain functioning, and also probably results in long-term damage because those cells are being starved of oxygen. Nicotine also constricts the blood vessels in the skin, producing cold, thin, and also smoking is associated with faster aging. You can go online and find pictures of people who have aged prematurely because of smoking. In fact, you can upload your own picture and see what you look like if you smoked. Does inhibit stomach secretions and stimulates bowel. In an intolerant person, it would actually function as a laxative, but it inhibits stomach secretions, and in fact, people often eat less, and in fact, it does increase metabolism of fat and dulls the taste buds, so people do eat less. It slows stomach contractions, but does increase blood sugar, which is obviously problematic. It may improve attention and memory, although at high doses it may cause nervousness, tremors, seizures, and panic attacks. And it may have an antidepressant effect, and there is some question about whether or not smokers are self-medicating. That's not been demonstrated necessarily, but it is something to think about. It certainly has a wide variety of actions. There is this interesting thing called Nesbitt's paradox. This is one of those very text-heavy slides, but I think it's important to understand. Nicotine causes arousal and causes release of epinephrine, so stress hormones. Yet most people say it relaxes them. If you gave somebody epinephrine, it would probably induce a panic attack. But smokers say smoking relaxes them. It may be relevant to the reason people smoke. It's an open question about whether it's simply a relief from withdrawal, or does it depend on the stress of the situation? Relaxation with high stress, stimulation with low. It's hard to say. Smokers report positive subjective effects if nicotine is given by smoking or intravenously, but non-smokers don't like it. So is there something about the smokers themselves? We do know that there are some specific genotypes that are more susceptible to nicotine addiction, harder to get off nicotine, and less likely to respond to a drug like Chantix. So there are some interesting issues with nicotine that make it very different from other types of drugs we've talked about or we'll talk about. Of course, I would certainly hope there's no surprise that smoking is bad for you. It's associated with heart disease. Nicotine increases workload of the heart. Carbon monoxide decreases the oxygen supply, which makes your heart work faster, increases arteriosclerosis and thrombosis in the coronary artery. So not only is it making your heart beat faster, it's less able to work as well because it's less pliable, and it's much more likely that you're going to end up with arteriosclerosis. Very important. Women who take oral contraceptives are at a much greater risk from arteriosclerosis and thrombosis or blood clotting than anyone else. So taking an oral contraceptive and smoking at the same time, there is a significant risk of heart attack, particularly with Yasmin or Yaz. This is a serious problem. These drugs ought not to be used together. In terms of lung disease, ash and tars are deposited on the moist membranes of the lung. Smoking reduces actions of the cilia and phagocytes that would normally clean the tissue, so you end up with that smoker's cough, which is fairly awful. You've all seen these, surely, in grade school. Of course, there's an increased risk of cancer of the lungs, mouth, and bladder, greatly increased by alcohol. Less than 10% of non-smokers get lung cancer. It's much higher for those who smoke. My father died of lung cancer, so certainly have some experience with that disease. Cigarette smoking actually reduces oxygen delivery to a fetus, decreases fertility in people who haven't had infants, produces smaller babies, more stillbirths, premature babies, and sick babies. It's a pretty significant and well-known side effect, and here's where I like to point out how problematic the tobacco companies are. In testimony before Congress, and you can look this up, it's readily available, a tobacco executive, when asked about lower birth weight of mothers who smoke, he said, and I quote, "Some women like smaller babies." So that's something to keep in mind about who we're talking about. Tolerance and dependence both can develop. There's a little biological tolerance. Smokers usually dose themselves with very consistent amounts of nicotine, as we talked about previously. As I'm sure you all know from friends who have tried to quit smoking, there is a serious withdrawal syndrome. These symptoms include irritability, anxiety, anger, difficulty in concentrating, restlessness, weight gain, and insomnia. That difficulty in concentrating is actually the area of research I've worked in, and we've shown in my lab in 3 different studies that while there are reductions in attention, particularly what we call visual attentional vigilance, the ability to detect a target in a visual space, essentially to sustain your attention over time, that's obviously reduced, but also there is a significant effect on memory primarily, and that is about a 30 to 40% reduction in memory. So it's best not to start. There is ongoing research to determine how long that might last and whether or not some of the drugs available to treat withdrawal symptoms might also benefit those cognitive problems. What happens is long-term nicotine use causes an alteration in the GABA system in the hippocampus. And because nicotine inhibits GABA, removal of nicotine during withdrawal causes an increase in relative GABA activation. And what we have shown is that heavy smokers show marked reductions in memory performance following 24 hours of abstinence, and this seems to be very differential for men and women. So there may be sex differences in withdrawal. So that's something to keep in mind. On that note, I want to next turn to talking about smoking cessation. Great benefits to quitting smoking. When you stop, your body begins to repair itself immediately. Within 20 minutes, blood pressure returns to normal and heart stabilizes. Within 8 hours, oxygen level in blood increases. Mucus begins to clear out of lungs. Within 2 days, senses of smell and taste improve. Chances of heart attack decrease. 3 months, circulation improves, immune system improves. Within 9 months, sinus congestion, wheezing, shortness of breath, and phlegm production decrease. I've never smoked, but I worked in bars for 20 years, and I can tell you that the whole time I worked in smoky nightclubs, I had sinus infections. I was always sick, and that has greatly reduced since then. Further after that, risks of dying of heart attack or stroke and lung cancer all drop off. So, how do we get out of smoking? Well, first thing is low nicotine content cigarettes are not useful. People just smoke more of them, actually increasing their risk of harm. You can do what we call nicotine replacement therapy, where you substitute cigarettes with either Nicorette gum or nicotine patches or nasal sprays and inhalers. The effort here is to reduce craving, and you can use other pharmacological interventions like antidepressants, including Zyban, which is Wellbutrin, or Chantix. All replacement methods are equally effective. They approximately double the quit rate of smokers without any help. And so that's very important. There is research about whether or not cognitive behavioral methods help with smoking cessation. It appears that there is some sex differences there. That is, men seem to do fine with one of these pharmacotherapies on their own. Women do much better with pharmacotherapy in conjunction with some support. And what the evidence indicates is that women are more likely to respond to cues that prompt them to smoke. And the irony here is that women probably have better, in fact, we know they have better memories. And so it may be that those cues associated with smoking are stronger and have stronger ties to the nicotine and are more likely to cue smoking behavior. So that's an important thing to keep in mind. About 90% of smokers stop without help, but you have to think about what's the most relevant factor in smoking. There is a pharmacological addiction, there are sensory motor effects, there are cognitive effects of withdrawal, there are social factors, which are decreasing with prohibition. It's getting harder and harder to smoke and much more expensive. So it's something you have to keep in mind, that as we move towards making it more difficult to smoke, and I'm all for smoking bans in buildings. I have no problem somebody smoking outside or in their home or in their car, but I really do think that smoking bans are the way to go. And there's a variety of evidence that shows that it makes people healthier, reduces cost to businesses. In fact, people oftentimes prefer that. In Atlanta, a lot of clubs are voluntarily going smoke-free because they've just found that their patrons enjoy it more. In terms of the addiction itself, about 10 to 15% of current alcohol drinkers are considered problem drinkers, but 85 to 90% of cigarette smokers consider themselves addicted to nicotine. Problem with smoking is there is rapid and frequent reinforcement. If you remember back to intro psych when we talked about reinforcing behaviors in operant conditioning, well, this is a behavior that's reinforced about 200 times a pack. Remember, every puff is a reinforcer. Also, it's very rapid metabolism. So clearance allows for frequent and repeated use, plus the rapid onset of withdrawal. And it does have some very complex direct pharmacological effects. And finally, there are social factors. That is, there are social rewards of being part of the peer group that smokes. And in fact, a lot of people are what we call social smokers. They smoke when they're out drinking. In fact, it's conditioned to other activities. People will smoke when they are drinking. Some people will smoke when they're driving in long car distances. Some people like to smoke when they're eating, which I can't imagine. But there are a lot of sort of paired associated stimuli that go along with nicotine. Factors that create the addiction also include there's no performance impairment from nicotine like other drugs of abuse we'll talk about. It's not like taking a couple of Vicodin and you're probably going to lay around and do nothing, or drinking a 12-pack where you're not going to be able to get to work. In fact, there is some evidence of improvement in alertness and reaction times. Relatively inexpensive, although I don't know. I suppose it's cheaper than cocaine, but probably not by much. No equipment needed. Not like you need a needle and whatnot. You just need a lighter or a match. Available at any convenience store. Portable, easy to store, and of course legal. We're going to talk about whether or not legal and illegal stops people from doing drugs very much, but And we'll also talk about price when it comes to illegal drugs. It's an important component of understanding the whole war on drugs. Okay, so all of these are factors that are related to nicotine addiction. So let's talk about this treatment of nicotine dependence. Pharmacotherapy is really the go-to route. Of course, we have nicotine replacement therapy, which includes gums, patches, inhalers, even those new electronic cigarettes that you've probably seen. The problem with this particular methodology is matching the dose appropriately. With the patches, they usually tell people to try certain sizes and step down. You can actually cut the patches to increase to 1.5, figure out the dose that works well for you. Gum obviously kind of replaces the cigarette itself. Bupropion, which is of course Wellbutrin or Zyban, is a pretty good alternative. And finally, there's a partial nicotinic receptor agonist called Chantix. And the great benefit of Chantix or varenicline is people can still smoke when they start it. So, in fact, the way to go with this treatment is people start on the Chantix and then over the next week start to decline their cigarette use. And in fact, they just naturally stop smoking. And it's really pretty remarkable. I have a good friend who just quit this way. I have, and the literature really does support this. In conjunction with pharmacotherapies, there's some really good things to do. Select a specific quit date. The important thing is that we don't have any substantial social or occupational dysfunction. There's less need for family involvement than other kinds of drugs we'll talk about, and there are effective over-the-counter treatments available. So you don't even have to go to the doctor. Obviously, Zyban or Chantix, you have to go to the doctor, but the other ones you can try on your own. They are expensive, though. Keep that in mind. So, from a clinical perspective, it's important to assess dependence. There are a number of ways to do that. The easiest is how many cigarettes you smoke per day. There's also this thing called the Fagerstrom test of nicotine dependence, which has some specific questions about craving. A score of less than 3 is low to nicotine dependence. Anyone greater than 6 is highly dependent. You can also measure nicotine and cotinine levels in blood, saliva, and urine. You can detect it within hours. Cotinine reflects tobacco use in the last 7 days. And carbon monoxide breath analysis is in the last few hours. In terms of assessing how good each of these treatments are, nicotine replacement therapies, good first-line choice. There are 5 FDA-approved nicotine replacement therapies, including patches, gums, lozenges, sprays, and inhalers. The problem here is matching the right dose, but you can combine these together. So maybe a patch and then an occasional spray from the nasal spray, whatever works is the important thing. And you can combine these with bupropion, which is also a good first-line treatment. The target dose is about 300 milligrams a day. So start people at lower. In fact, oftentimes what they'll do is they'll start them out on a low dosage 7 days prior to their quit date. After 3 to 4 days, they increase to 300 milligrams, so 150 milligrams twice a day. Side effects can include jitteriness, insomnia, and GI symptoms. Remember, this is a dopamine reuptake inhibitor. You can also get seizures. We want to make sure we don't use this in people with eating disorders because there are some serious problems there. Varenicline or Chantix was proved not long ago. It's a unique monoamine oxidase inhibitor. It's a partial agonist at nicotinic acetylcholine receptors. Blocks the ability of nicotine to stimulate acetylcholine receptors, thus blocking activation of the dopamine system. So smokers don't get the reward from those cigarettes anymore, and you can actually break the link between the cigarette and the reward. The elimination half-life of Chantix is 24 hours, so perfect for once-a-day dosing. Most of the time it's after meals and with a full glass of water. The recommended dosage is 1 milligram twice a day, following a 1-week titration as follows. Days 1 to 3, 0.5 milligram. Days 4 to 7, 0.5 milligram twice a day. And at day 8 till you finish, 1 milligram twice a day. The course of treatment is about 12 weeks. and then another 12 weeks if they're abstinent. The most common side effect is nausea, but it is particularly effective. So if we take a look at the data, the dark bars are varenicline, the dark gray are bupropion, and the white are placebo. You can see very clearly for the first, for weeks 9 through 12, about 45% of the varenicline group are still abstinent compared to 30% of those with bupropion, so about 50% better. More than 3 times as many people are still abstinent than those who were given placebo. When we get up to weeks 52, which is, of course, a year, 20% still abstinent. Pretty good rate. You can look at, of course, dosing, which one works the best. All of them show that Chantix is a pretty good choice. All right. So the point here is they're a great alternative to smoking, and people can get off. Again, there is some evidence that this may be genetically determined, but there is research in that is ongoing. Please, if you have any questions about these, don't hesitate to drop me an email or text or drop by my office. I'm happy to talk to you about it. All right, next we're going to turn to recreational drugs. I think up next are cocaine and amphetamines. So we'll talk about that next time.